Most commonly, myositis ossificans presents radiographically when calcium deposits are noticed within the muscles, often of the upper or lower extremities that have sustained physical trauma. As you'll see from the name of the fact, the name scleroderma is not as commonly used anymore, and actually has in part been replaced by the term progressive systemic sclerosis. You should think about this disease as a widespread, diffuse, uncontrolled deposition of collagen leading to fibrosis in the body that, like most common autoimmune diseases, mostly affects females. As per the name scleroderma, this often happens in the skin, appearing with puffy and taut skin without wrinkles. However, many other organ systems are affected, including the renal, respiratory, cardiovascular, and GI systems, which are the primary cause of mortality, not the skin changes. There are two major types you should know for step 1. The first is called diffuse scleroderma, and this is exactly what it sounds like, a widespread disease affecting skin and many visceral organs. It's rapidly progressive. The antibody most often associated with this is SCL70, an anti-DNA topoisomerase enzyme. The second type is a form of limited scleroderma, which affects skin areas more specifically. This is called Crest syndrome and stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. Usually these patients have fewer skin findings than people with diffuse disease, and if they do, you tend to see it on the fingers and face. The antibody here is different. It's the anti-centromere antibody, as referred to in the name. Remember, this presentation won't necessarily sound like scleroderma immediately, because there really won't be that many skin findings. Instead, there might be non-specific findings on the fingers, some vague history of GERD, cold intolerance manifested by Raynaud's, and x-rays of the hands indicating calcium deposits under the skin. This section is a crucial one for you to understand as you transition into your wards experience and also as you try to learn about the next 2 pages of first aid. This guide attempts to explain the difference between seemingly similar dermatologic terms. Some examples have been provided here to help you with this. Let's start by talking about the first 4. A macule is simply a flat discoloration of the skin that's less than 5 millimeters in diameter. If, however, the discoloration were greater than 5 millimeters, this would be a patch. Similarly, if the skin lesion were less than 5 millimeters but elevated, it would be a papule. If it were more than 5 millimeters and elevated, it would be a plaque. A classic example of a papule is a small pimple like you might find in acne. However, plaques are more extensive skin lesions, like the ones you'll see in a patient with psoriasis. A vesicle is classically just a small fluid-filled blister like you would see in chickenpox. If it were bigger, it would be called a bulla, but the terminology distinction is a bit vague here. If the blister were filled with pus, it would be called a pustule. If vesicles, bullae, or pustules pop and crust over, they form a dry exudate, which is called a crust, and which is a common finding in impetigo. This list contains terms related to the architecture of the skin when you look at it with a microscope. If you remember the image of the 5 layers of the skin, remember the mnemonic Californians like girls in string bikinis to remember the names of the layers. We'll see how different pathologies will have classic findings on histology. In diseases like psoriasis, a common finding is the thickening of the stratum corneum, the topmost layer, which is called hyperkeratosis. If the cells of the stratum corneum still had nuclei, it would be called parakeratosis. In other diseases, parts of the epidermis can increase in number, primarily the spinosum layer, and create what's called acanthosis. If the same layer splits apart, as occurs in other blistering diseases, it's called acantholysis. Can you guess the name of the general inflammation of the skin? Exactly, dermatitis. The next set of diseases we'll touch on are the diseases of pigmentation. There are 3 of them we'll discuss here, but there are in fact many more. Some terms, like albinism, are general terms that describe a spectrum of diseases. One form of albinism is caused by a decrease in the function of the tyrosinase enzyme, a critical enzyme in the formation of melanin. If you looked at their skin histologically, would you expect to see changes in melanocyte number or average melanin production per melanocyte? You'd expect to see the same number of melanocytes, but each melanocyte produces less melanin. A different form of albinism occurs as a result of poor migration of neural crest cells into the skin. In this form, the melanocytes, a neural crest type of cell, never actually make it to the skin, and therefore a decreased number of melanocytes is the actual cause of the disease. What's another disease that results from migration failure of neural crest cells? Exactly, Hirschsprung's disease. Refer back to the GI chapter for more details. A different disease entirely is called vitiligo. Here the problem is more focal and not as generalized as it is in albinism. The main reason for the disease is because of a decrease in the number of melanocytes. This is usually the result of an acquired phenomenon, which means the neural crest derivatives made it to the skin and were working fine until some idiopathic insult caused them to be destroyed. As a fun side note, this is a disease that Michael Jackson claimed caused his progressive skin problems. A final skin pigmentation disorder is the one seen in pregnancy, which is called melasma, or the mask of pregnancy. You often will see this in patients with oral contraceptive pill use as well, indicating the role of hormones in this hyperpigmentation. Now we're going to discuss 5 different classes of skin disorders, the first of which is just the common ones you may see. Then there are disorders of pigmentation, infectious disorders, blistering disorders, and finally some miscellaneous disorders. Let's start with the common disorders. If you look at them under microscopy, they appear to show epidermal hyperplasia, as well as hyperkeratosis and chondrocytosis. There are many different types of warts, from the commonest form, verruca vulgaris, that might appear on the hands, to condyloma acuminatum, which can appear in the anus or genitals. The latter is known to be caused by HPV type 6 and type 11, not the types associated with cervical cancer. The second common skin lesion is the nevocellular nevus, which is a simple common mole. Urticaria is the term used to describe hives, which are in fact wheals that are itchy and secondary to release of inflammatory factors from mast cells. You can see these in a wide variety of allergic responses. Ephellus is the technical term for a simple freckle. It's important to know that freckles are actually small areas of skin with the normal number of melanocytes, but actually melanocytes that just produce excess melanin pigment. Atopic dermatitis is an important disease to know that you likely already know is more commonly called eczema. Eczema is classically itchy and occurs in many areas over the body, particularly in the flexures of the extremities. Usually, atopic dermatitis is just one piece of a greater atopic triad, which includes asthma and allergic rhinitis. Atopic dermatitis is often compared to a different dermatitis called contact dermatitis. While you'd expect atopic dermatitis to come on very quickly since it has some allergic and therefore IgE-mediated signaling, allergic contact dermatitis does not follow the same rule. Here, the skin changes result from a delayed type hypersensitivity reaction. You remember what type of hypersensitivity reaction is delayed onset? Yep, type 4. The classic example of this dermatitis is the reaction people naturally have to poison ivy. If a patient comes in claiming to have contacted poison ivy only 30 minutes prior, and they now seemingly have a reaction on the skin, it's unlikely to be poison ivy only because it takes a couple days for the reaction to develop. This is another great example of how questions can be answered by knowing chronology of diseases and rapidity of onset. Another common disease that we've discussed to some degree is psoriasis. The classic lesion in psoriasis is multiple salmon-colored plaques with silver scale over them, particularly on the extensor surfaces of the extremities, i.e. the knees and elbows. Interestingly, when you look at the skin of these patients under microscopy, there's both acanthosis, meaning an increased spinosum layer, parakeratosis, meaning nuclei retaining the corneum layer, and a smaller granulosum layer. You should definitely memorize these findings, as their presence is usually a pretty big hint that the answer to the question is psoriasis. There are a few diagnostic clues that might help you to confirm the diagnosis in a patient who presents with a rash. The first is Auspitz sign, which means that when a scale on the lesion is scraped off, the spot will tend to bleed. The second clue that you might get is that psoriasis is a systemic disease that doesn't only affect the skin. As we've already discussed, there's a seronegative spondyloarthropathy associated with psoriasis, often called psoriatic arthritis, and patients may present with those symptoms first. The other association that exists is often nail disease, commonly described as nail pitting, but there can be a whole variety of disease manifestations. The final common skin lesion we'll discuss is the seborrheic keratosis, or SEBK. It's a flat, greasy, pigmented skin cell tumor that includes keratin-filled cysts, or horn cysts, and happens most commonly in older adults. It's classically described as looking like it's pasted or stuck on, but can't be scraped off, and it can happen anywhere on the body. The classic board-style question about the skin finding is that it can reveal an underlying disease. There is, for example, a sign of Lessard-Trellat, which manifests with appearance of multiple SEBKs rapidly, indicating an underlying cancer, often of the GI or lymphoid systems. Now let's turn our attention to the blistering disorders, of which there are 5. The first 2 we already talked about to some degree when we were discussing the desmosome and hemidesmosome. As you might remember, pemphigus vulgaris is a blistering disease that's marked by the finding of IgG antibodies against desmoglein 3, a part of the desmosome. This causes segments of epidermis to lift off away from one another, which leads to the formation of intraepidermal bullae. It can be very severe. There are 3 classic comparisons made between this and bullous pemphigoid. The first is that when you look on immunofluorescence, you'll see a net-like pattern because the antibodies can be found throughout the epidermal layers between keratinocytes. In contrast, the IgG antibodies against hemidesmosomes found in bullous pemphigoid only attack at the basal layer of the epidermis because that's truly where all the hemidesmosomes are. This appears like a line instead of a net. This means when the hemidesmosomes are destroyed, the epidermal layer lifts off the dermal layer in one untouched piece. The second distinction that's often made is that pemphigus vulgaris will affect skin and oral mucosa, while bullous pemphigoid only affects the skin and not the oral mucosa. Finally, the Nikolsky sign is positive in pemphigus vulgaris and negative in bullous pemphigoid. This means if you were to stroke the skin would quite literally blister in front of your eyes. While this is a classic description, the other clinical indicators are more likely to help you make the distinction. The third blistering skin disease is dermatitis herpetiformis. When you think about the word, it quite literally is a skin inflammation that appears like a herpes infection. If you look at this under IF, the appearance of IgA at the tips of dermal papillae, which causes the tips of the papillae to light up like snow caps along mountains. The papules and vesicles are itchy and are usually found on the extensor surfaces of the skin. It tends to be boards relevant because of its association with celiac disease, which in some cases may precede the appearance of GI symptoms. Do you remember what type of hypersensitivity reaction this represents? It's a type 3 reaction due to the deposition of IgA immune complexes. The final two blistering diseases are erythema multiforme and Stevens-Johnson syndrome, which probably shouldn't be thought of as classically blistering diseases. Erythema multiforme and Stevens-Johnson's are the two ends of a spectrum that occur as a result of drug reactions, much like the spectrum of cellulitis and necrotizing fasciitis. Erythema multiforme is the most benign reaction, while Stevens-Johnson's is much more serious and potentially life-threatening. Let's start with erythema multiforme. It classically shows with multiple types of lesions, usually with macules, papules, and vesicles, and some targetoid lesions, a classic finding. Many drugs cause erythema multiforme, including sulfa, beta-lactams, and phenytoin. Additionally, you might see erythema multiforme as a result of certain infections, like mycoplasma and herpes simplex, but this is a less common association on the boards. The other even less common possibility is that it results from cancer or autoimmune disease. It's worthwhile to know these associations, but you should keep erythema multiforme strongly linked to adverse drug reactions for the purposes of the boards. Stevens-Johnson's, in contrast, has more concerning skin findings, usually including bullae with necrosis, particularly orally, and it's often found with systemic signs like fever. It occurs at the same time as another skin disorder called toxic epidermal necrolysis, which causes large areas of the skin to slough off, making it a life-threatening condition.